All right, good morning, everyone. Thank you so much for joining us. I'm very excited for today's conversation. My name is Anna Lynn, and I'm the Mental Health Promotion Coordinator at the Minnesota Department of Health. If you haven't been here before to this mental well-being and resilience learning community space, we lift up initiatives that focus on mental health promotion and prevention. And we think about mental health in the very broadest sense. So hopefully you can see this definition on your screen. Can you all see that? I'm looking for some thumbs up or something in the chat just to make sure that everyone can, in fact, see my screen. Okay, yes, thank you, Chelsea. All right, so this is the definition that we center in these conversations, the World Health Organization definition. I should know this off by heart, but I still read it. And that is a state of well-being in which the individual realizes his or her or their own abilities, can cope with the normal stresses of life, resilience, can work productively and fruitfully, and is able to make a contribution to his or her or their community. What I like to say is I hope that you see yourself in that definition, because this isn't about other people, it's about us. We all have mental health and we all need supports and resources and connections to promote our well-being. And I have multiple screens and I can't change. Okay, here we go. So if you haven't seen this before, this is the dual continuum of mental health that was popularized by Dr. Corey Keyes, who talks about the relationship between mental illness and mental well-being, or you might use the word flourishing and languishing. These are related concepts, but they're different. Normally, we think about mental illness as like either you're mentally healthy or you have a mental illness or you're good. But really, we know that there are a lot of things that we all need to support, to flourish, to be living that definition that we just talked about, whether you are managing an illness or not. And so they're actually two different continuums. And the longer that people are maybe languishing without a diagnosis or condition in this bottom right-hand quadrant, the more likely they are to develop an illness. And we understand this when we think about our physical health, right? You might not have heart disease, but you might not be really like healthy. But we don't always think about it that way for mental health, but it's very similar. And so I'd like to share, and what we're trying to do in this space when we talk about promoting mental well-being is we're trying to move everyone up to the blue, right? To think about all the things that we can do to support our well-being so that we're all flourishing. And there's a lot that we can do, right? There's so many things that contribute to our mental health and our well-being. We know that relationships, connections, and belonging are critical. We know skills, some of like we're going to talk about today. We know that community, culture, and spirituality or connections is something bigger than ourselves is critical. Of course, healthy lifestyles, sleep, food, exercise, equity, and social health policies, things that we often don't even recognize the impact it has, are critical for our mental well-being. We know there's opportunities to address trauma and healing, supporting our basic needs, and of course, environment. We talk a lot about that here in this space. Opportunities to connect to nature and even the built environment are critical. And then our communities need capacity to address all these things. So there's tremendous opportunity, overwhelming opportunity to support our mental health. Today, we're going to talk a lot about what we call community-initiated care. This is the future of mental health. And the bottom line of what community-initiated care is what you see on your screen. Like minimal definition is it's about empowering and equipping people, regular people, individual community members to support each other and promote our mental health and well-being. There are so many things that really drive the need for community-initiated care. Specifically in the United States. Many other countries have already adopted these practices because of the need. and the opportunity, right? But in the US, we have a chronic workforce issue. And yet we have 145 mental health workers per 100,000 population, which is way more than the average across the world. And yet only 42% of people with what, might reach the threshold for a mental health diagnosis actually get support and treatment. And we know access is worse among BIPOC communities and LGBTQ. The cost, we are spending a lot of money on treatment. And now no one's saying like we need both and, it's always a both and solution here, but the cost, we're spending over $250 billion, billion with a B, annually in the United States. And that's probably just on medical costs, not on the ancillary costs that families incur and others incur on that road to getting support. The other really two critical drivers are the biomedical model often doesn't recognize the social conditions, the social collective trauma or the other social conditions that we talk about in public health quite a bit, right? That drive our need for care and, or drive our health rather. Like when we talk about medical care, we know that only, that health insurance or health care only covers about 20% of what we define as health. I don't know what the exact numbers are for mental health, but I imagine it's probably pretty similar. And then there's been a really shifting understanding about mental health that in many cases, the experiences that would drive us to get treatment are extreme, but normal, like versions of a common or normal life experience. And so the opportunity to provide supports amongst our communities and families is tremendous. So I'm just setting up our presenters today to dig more deeply into that. But before we pass it over, I'm going to tell you a couple of things that I also always talk about, and that is MinThrives. If you haven't been on MinThrives, it's a database, an online database that highlights or captures efforts, initiatives, programs, projects that people in Minnesota are implementing to promote and support mental health and well-being. We recognized long ago that we can't capture everything here in a once a month webinar. And so we wanted to create a space where people could share what they're doing so that we can learn from each other. So folks in Bemidji learn from folks in Mankato, learn from folks in Duluth, and that's what this is. It doesn't have to be fully formulated. You could be doing something amazing. Please, it's crowdsourced. Please add your information about the work you're doing into MinThrives. It's very easy. It's an online survey. If you need help, reach out to me. I will help you physically enter it into the database. It'll take us 15 to 30 minutes. Just as a teaser, here are a couple of things you might find on there if you explored MinThrives. There's so many rich examples of things that are happening from informal to very formal efforts. Here is one that I actually hadn't seen before, and I've been on this many times. So the Teen Talk podcast in St. James. This is a partnership between St. James High School, the Team Up Student Council, and St. James Youth Council. It's a podcast run by youth, young people. They have topics, it started during the pandemic. They have topics that they cover everything from belonging to social media, to relationships, to life balance. Adults contribute, but they share their perspective and insight, but it's really driven by the teens. They have 3 seasons and 21 episodes so far, and looks like they're continuing to go forward. And the fun thing, if you want to look it up, is they share when they a song of the week, or at least they did for the beginning part of their season. So hopefully that continues. If you want to reach out and learn more about this, maybe you think, hey, we could do that in our school. Stephen Chapin is the contact, and here's the website if you want to check it out. I'll put it in the chat and in the follow-up email as well. Another really cool communities helping communities is this example of neighbors helping neighbors. It's a faith in action program where they connect people who want to help with somebody who needs some help and support. Everything from rides to visiting, phone reassurance. That's a great term, isn't it? Phone reassurance. Caregiver support, homemaking, basic home repairs. Volunteers benefit, so they recognize that we actually benefit when we support other humans. We get a boost for our mental health. So it's a win-win. There's no fees, no income, no age restrictions. Their intent and their expectation is that this builds community, reduces isolation, and it removes barriers to accessing services in the rural area. If you want to find out more about this, Teresa Eclove, I'm not sure how to say, is the contact, and there is a link, website, Faith in Action in Cass County, Minnesota. Cool. Okay, final plug. I know you're doing cool stuff. I hope you can take just a few minutes to log into MinThrives and add information. If you realize that you want to change it, you can go back in and change it. You can email me or reach out, hey, I didn't, include this, or this was wrong. We can update it. So you don't have to be afraid. It's very easy. And if you have a network or group that you want to promote this tool to, I'm happy to do a little presentation or equip you to do a little presentation about this tool. So help me promote it and help me populate it. So thank you for your work. One very quick announcement. I don't have a lot of announcements this summer, I guess, right? People are doing other things, but there is a very cool upcoming event. This is Metro, but I'm kind of sharing this to inspire maybe others to think about this. There is a group called Living Naturally Abundant that's hosting a community wellness dinner. So a meal with some experiences of well-being practices in St. Paul at the Hallie Q. Brown Wellness Center on Wednesday, August 26th in the evening. You can register. I'll send this also in the follow-up email. The QR code is there, or you can look it up, called Nourish Community Wellness Dinner. All right, super excited to hand it over to the leaders of Miller-Dwan Foundation and ArcaMind. We have Traci Marciniak, the president of Miller-Dwan. Annie LaTour Schwartz is the program manager at ArcaMind, and Rick Gertsema is the senior mental health advisor at ArcaMind. They're going to talk to us today about their work to promote community-initiated care. Thank you. And if you have questions along the way, you can put them in the chat. If this is about clarification, we'll definitely jump in and make sure that we get that answered right away. If it is not, it's questions that we can answer at the end of their presentation, we will do that. And there'll also be opportunities if you want to jump in and become one of the panelists. We'll bring you in and you can ask it yourself. Yeah, all right, I'm going to stop sharing. And then maybe I'm going to stop sharing and then hand it over to, oh, here we go. I have 3 screens and I can't find my cursor. Where is it? Sorry, my cursor is somewhere. Can you share? Maybe that'll just disrupt my sharing. Oh, here we go. Okay. Did it. All right, it's all yours, Annie. Thank you all for joining us. Traci, Annie, and Rick.
Thanks for having us.
We see your screen, or we see your slides.
See it now. Annie, did you want to start by giving a little background about who you are? Oh, you're on mute.
All the technology. Good morning, everyone. My name is Annie Schwartz. I'm the program manager at ArcaMind and happy to be here talking with you today. I'll turn it to Rick to introduce himself.
Good morning, everybody. Welcome. We are thrilled to be here to talk about our work of bringing World Health Organization strategies into the United States. I am a child adolescent psychologist by training. I started in mental health in 1982 and joined the Miller-Dwan Foundation about 4 years ago now. And so I'm the senior mental health advisor in this capacity. And I will pass it on to our president and CEO, Traci Marciniak.
Hi, everyone. Thanks again for having us. I am Traci Marciniak. I am the president of the Miller-Dwan Foundation and CEO of ArcaMind. A little bit of background for everyone. ArcaMind is actually a division of Miller-Dwan Foundation, which is an independent healthcare-focused foundation that's based in Duluth, Minnesota. Miller-Dwan Foundation has had a very long history of supporting behavioral health care across the lifespan. I think probably one of the things we're most known for is Amber Wing Center for Youth and Family Wellbeing, which is a child and adolescent partial hospitalization program that is here in Duluth. We own that facility after creating it back in 2012. Essentia Health is our care partner within that facility. If you want to go to the next slide. Here's our agenda for today. We'll talk a little bit, well, which I just did, about ArcaMind, why that came to be. We're going to talk about the training opportunities that ArcaMind provides and dig a little more deeply into what those mental health interventions are that we specialize in. So next slide. So I think this is probably not a surprise to any of you based on the work that you do, but what we have done at Miller-Dwan Foundation, I mentioned that we've had a very strong focus on behavioral health. And these statistics, I think, were something that our board of directors got a hold of at some point and really thought, oh God, you know, we're in the midst of a mental health crisis. And as you all know, we were in the midst of a mental health crisis before the pandemic. And when the pandemic actually happened, it exacerbated it quite a bit. So, you know, as we look at these NAMI statistics and we compare them to Minnesota, what we know is actually some things are actually worse in Minnesota. So, you know, there's 1 in 4 people who have been adults that have been diagnosed with depression in Minnesota. And our rates of depression throughout the state continue to increase, unfortunately. And when we look at young people and suicide being the second leading cause of death, what we know in Minnesota that the highest prevalence of diagnosis of mental illness is between the ages of 18 and 24. So next slide, please. So again, we know that the need continues to grow and the access to care continues to be a gap. One of the things that we have known being in the Duluth area is that all of the counties within northeastern Minnesota that we have primarily served throughout our history have been designated as mental health provider shortage areas. And that does not seem to be getting any better. And when we look at the difficulty that people have accessing care, it really prompted the foundation to start thinking differently about how we can do things to allow people to access care in a different way. What we know, and you know, Rick and I have worked together for many years, and prior to him joining Amber Wing, he worked with Essentia Health, which is one of the primary healthcare facilities in the Duluth and upper tier of the state. And he was manager of the ambulatory behavioral health services. At the point in time that he and I were talking during the pandemic, he had mentioned that what went from 500 referrals a week to behavioral health services actually shot up to 1,500. And that's when we really started thinking about there is no possible way that we're going to be able to provide the necessary care to the amount of people that need it using the systems that have already been in existence. It was really that idea of how do we do this differently and do it effectively. So next slide. So based on that, we created ArcaMind, and our goal with ArcaMind is to solve the mental health crisis not only in our region, but throughout the state of Minnesota and the country. We know what has been done over the years has not been able to meet the need. So we wanted to start thinking about how do we provide care differently in a manner that allows people to access it easily in areas that they trust, with people they trust, and really figure out how to support the existing licensed workforce, because we know that we're never going to hire enough licensed professionals to solve this crisis. So what we started doing, and Rick can talk a little bit about, his exploration into, what's working around the world that we haven't necessarily seen here in the United States. And what we ended up finding were these really wonderful World Health Organization mental health interventions that were created and used widely across 20 countries around the world and used very, very successfully. And we started talking about, well, why can't we do that here? And, what we wanted to do was create that whole new level of workforce that really supports the folks who are needing to see people who need that very high level of care. So when we talk about ArcaMind and the training that we're doing, what we're doing is we are training lay people to be able to provide a mental health supportive intervention within the community without having to rely on licensed individuals for everyone. So I will turn it over to Rick to talk a little, or turn it over to Annie to talk a little bit more about these interventions and why they work so well.
Great, thank you, Traci. I'm going to give kind of a high-level overview, and then we'll dig a little deeper into two of the primary interventions, which is PM Plus and EASE. But just to say, all of the interventions are really this prevention-based approach. So while you have kind of a continuum in any population, you have people who are doing well, you have people who may need a higher level of support always, but then there's a number of people shown in purple in this diagram that we would categorize as distress. That might be temporary, or it may be, due to a natural disaster, a death in the family. It could be a number of things, but they don't need a high level of care, kind of middle to moderate stress. And that's what these interventions really focus on, getting them the skills to help themselves. How do you manage through that time of stress? How do you get to that doing well without necessarily needing clinical care? So when Traci was talking about that 1,500, probably not all those people needed it. If they had some of these skills, they would get themselves to that doing well phase. But during this intervention too, there is also supervision by a licensed professional, and always screening to make sure that people, if they do need a higher level of care, there is a referral process and kind of safety net in place. But ours really focus on that prevention. So this is the overall menu. I think this has been a pilot phase over the past couple of years, and just really a lot of learning on how these interventions work. And I think we realized early on that not one size fits all. So we had focused originally on PM Plus and now have more of a menu approach to have different levels of interventions for different needs and different organizations. So we have these level 1 interventions that are really more of a light touch. You'll see they're 2 to 3 hour sessions, usually one time. Psychological first aid, I think many may be familiar with that, but that's really outwardly looking. How do people help within their community, identify people who may need help and get them to know the resources to refer them to. We'll talk a little bit further about each of these, but just at a high level. And then Self-Help Plus, which is really looking internal. This is kind of a self-guided approach, really focused on mindfulness and those types of skills. The level 2 is more of a manualized approach and multiple sessions. So we started off with PM plus individual. So it's 5 sessions. Rick will do a much deeper dive into this, but it's 5 sessions with an individual with one of those trained lay workers. That can be also done in group. And then as we were doing that, I think the WHO actually just came out with a youth version for 10 to 15-year-olds. So we're in the process of piloting that, that intervention. That's 7 sessions, and then complemented by 3 sessions with caregivers. We also have DBT, which we call level 3. So Traci mentioned Amberwing, which is a partial hospitalization program that models, the model used there is DBT, dialectical behavioral therapy. We do training with a lot of the schools in the area, so there is kind of a smooth transition for the children who are in the Amberwing program back into the school. So we're working with school counselors, some paras in each of the schools to understand DBT, to speak that similar language so they can continue to support those students that need a higher level of support. So just to say that all the interventions that we're using, almost all of them except DBT, are WHO. So they're proven interventions with years of research. WHO doesn't lightly put their stamp on things. So we're confident that these really are evidence-based. Each of the curricula has a different focus or audience. So it creates a stepped model of care over time. You can create, the level 1, level 2, and level 3 could be in the same organization, or an organization may just use one. So that's, or one over, and then build into something else. So it's creating, I said, stepped care model and just a different set of options. So I'm going to turn it over to Rick. He's going to go a little deeper into a few of the interventions.
Okay, here we go. So now we're going to talk about the fun stuff, talk about actually the interventions themselves. And as we talk about that, that tier 1, really one of the first places to begin, we've learned with organizations who have not had a lot of exposure to mental health interventions, or there may be a lot of stigma associated in those communities, is we start with psychological first aid. Many of you may know psychological first aid, and then there's also mental health first aid. Differentiating those two is that psychological first aid really is more actionable. So the tenets of psychological first aid are look, listen, and then link. So looking, daily life, observe people who are under stress and be able to identify exactly what that might look like. What does it look like? What do you listen for? Introduce yourself and talk with people without pressuring them to tell you what you think you want to hear. Just being present, being mindful with them. And then the actionable piece is, what about link? How do we get people connected to the kind of services or the kind of support that they may need? Really very much a public health and community involved initiative. As an example, we just trained more than 500 logging professionals in the logging industry across the state of Minnesota. And that was really their introduction into mental health and mental well-being, because there'd been a rise in suicide rates. And so how do we really think about that? Level 1, how do we open the door to start thinking about what is look, listen, and then linking? We also did this training with 100 different school staff in the Duluth public schools. We're going to then, in the fall, continue with training with the logging industry, and that will be a continuing relationship. And then thinking about, is there a place once they have the level 1 interventions that they might want more, or they may want to be more involved with level 2 interventions. So, and if you want to go to the next screen, please. And this is in progress. It's a very exciting project. This is Self-Help Plus, which is also a World Health Organization intervention. And this is, it can be a self-pace. We're creating videos. So on the left-hand side of your screen, you can see that it's going to be a more animated, so it's more engaging. Self-Help Plus was created in other countries, like Traci was talking about, with the majority of the WHO interventions. And it was actually just an audio, and they were long, boring, terrible things to listen to. So we're creating animation, and what you'll see is that there's 5 sessions, and it can be your own self-pace in which you listen to how do I get myself grounded, really talking about mindfulness, unhooking from your emotions, especially when we're under stress. When we get under stress, we keep going back to the stressor and the stressor. So it's like we keep refiring ourselves. So it's unhooking from those, and then acting on your values, thinking about what are our own values and how do we reconnect and act on those values, being kind, and then making room. So making room is thinking about, if you look up at the sky and you see the clouds roll by, really letting your emotions move by you rather than trying to stop the clouds from moving in the sky, because you can't stop the clouds from moving. Our emotions are a natural part of day-to-day life. So those are the first 2 steps. We're expecting by the end of the summer, we will be able to have Self-Help Plus available. And we've also created a learning management system in which these interventions live. If you want to go to the next screen, please. So now Problem Management Plus. What I was able to discover, Traci, when I started with the Miller-Dwan Foundation, asked me to take a look at what's happening locally, regionally, statewide, and globally. It was so clear to me after decades of working in mental health, there's got to be a point in which public health and mental health can create a marriage, because these interventions actually were created in the public health arena. So it really is the people who, you meet people where they live, you meet them in their community, you meet them in a place with relationships that already exist. So PM Plus really has 2 facets. We have the PM Plus helpers, who are the lay professionals or non-licensed people, and basically people who have good basic helping skills, want to be able to help, and want to engage and try to help people improve their low to moderate stress and the adversity that they might be facing in their life, as defined by the client. And then the second facet is the individuals who are actually receiving PM Plus, who have been clients. And I think the real important piece here is that these interventions, like have been happening globally in 20 other countries, these interventions can be adapted to nearly any population. We have learned in the last 2 years that from the faith community to the rehab community to an arms worker who said every single person in human services should be trained in these strategies. So what we do know, and we have the flexibility, is to take these strategies and make them adaptable to the context in which the community would be presenting to us. If you'd like to go to the next slide. And here is actually PM Plus. It is a 5-session intervention, and as Annie said, PM Plus can be delivered either individually or in group. And if you look at session 1 as an example, you can see that it's manualized, and there's actually a checklist that, as a helper, this would be your guide. You know that when you meet with your client for the first time, a person who is experiencing low to moderate stress, not a crisis intervention, the very first thing you're going to do is spend 5 minutes introducing yourself and talking about confidentiality. We always want our clients to know that the work that's done between a helper and a client is confidential, unless there's an imminent danger, which of course we also talk about risk assessment. And then during every PM Plus session, there's something called a Cyclops. It's an outcome measure that's a self-rating scale that the client themselves complete each session. So we talk about what's the number one problem that's happening in your life, and let's rate that. How much has that affected you on a scale of 0 to 5? What's the second biggest problem that you're facing? How much has that affected you? And then we ask, what's the one thing that's really hard for you to do? And then we rate that as well. And then from session 1 all the way through, as you look through session 2, 3, 4, and 5, you see we always begin with the Cyclops so that the client will be able to identify themselves if they feel like their problems are affecting them less and less as they are going through the 5-step intervention. So after the Cyclops, now as a helper, you know the adversity that the client is facing because they just told you their top 2 problems. So then we're going to introduce PM Plus, talk about the 5 sessions, talk about ideally for the next 5 weeks, we're going to meet, and it's going to be about 60 minutes per session. Session 2 sometimes can be a little bit longer. And then we're going to talk about adversity, understanding adversity. So talking to the client with the problems that they presented, I understand those are really difficult circumstances. It could be end of life issues. It could be that I just lost a spouse. It could be that I just moved and I don't know anybody. We've also done work with the International Rescue Committee, the IRC in Atlanta, for refugees who are coming into the United States from other countries. So we talk about managing, understanding that adversity, and then we talk about managing stress. And managing stress is all about mindful breathing. So we teach people, how do you breathe again when you're under stress and really struggling? Because what we typically do is we breathe in a shallow way and we send our body into fight or flight. What we want to teach is how can you get yourself grounded and take time that you can do mindful breathing. And then we create an action plan. So there's always an action plan at the end of every single session. So very specifically, when are you going to practice your mindful breathing? How are you going to remind yourself? How long do you want to do that? And then the first thing we do when we come back for session 2 is we revisit that managing stress.
Rick, there's a question in the chat about if these interventions materials are translated. So since you mentioned immigrants, communities, and then another question that Traci started to answer, but maybe you could build on, is if PM Plus is available for younger people, 15.
Okay, so younger, translated, yes.
Translations.
So thank you for that. Yes, PM Plus is translated currently into a number of different languages, globally, of course. In the United States, Spanish. I know that we've done translation for Afghan population, Venezuelan population. So yes, all of that can be adapted, and it has been. There are translations. Go ahead, Andy, if you had something to add.
I think they're currently in Hmong Dari and Spanish in the US.
Perfect. Perfect. In terms of age group, PM Plus has been used for kids as young as 16. It really, in the United States context, again, we're the second city in the United States to be launching these interventions. Second to New York City, there was a project called Recoup New York, which we connected with and actually then moved into a pilot project with the New School for Social Research in George Washington University. So it has been used 18 plus, and it has been used as young as 16, and there was a group in Superior with a school counselor who actually did PM Plus with 16 and 17-year-olds in the high school. If you want to go back to the last slide, Annie, please. You want to go back to the PM Plus slide? There we go. So, managing problems. Session number 2 really is a general review. Teach people to manage problems, not solve problems. There's a seven-step process that it's all in a workbook. We created a workbook for these interventions as well. And then creating the action plan. Get going, keep doing is really about behavior activation. And how do we get people out of their inactivity cycle? Because as human beings, we say, as soon as I feel better, then I'll do that. We know you need to start. You have to get back into your activity cycle. So we pick one small thing out of a list in which you find joy and create an action plan for that. And then session 4 is how do we strengthen social supports? So with many of our clients, many people, when they're experiencing distress, social support systems shrink to people who are closest to us. And so we really want to talk about how do we spread that? How do we grow that social support system? And then session 5 is how do we stay well? And again, you can see with each of the sessions, time allotments, session checklists, and you know exactly where you're going if you're a helper. So now if you'd like go to the next slide, please, Andy. So we know we have proven effectiveness of PM Plus globally. It significantly improved mental health issues, anxiety, depression, which is also very parallel to our pilot project that we did locally in the Twin Ports of Duluth and Superior, Wisconsin. It's feasible, acceptable, and safe. It can be adapted and effectively delivered by trained helpers to a wide range of common mental health concerns. Next slide. So locally, evidence has shown us it increases care options. Psychological distress is decreased as are symptoms of depression and anxiety. It reduces stigma, the whole idea of talking to somebody about what our mental health stressors are, because they're people that are known. The helpers are within communities. It's cost effective. There's a high engagement of helpers and the program participants. So the helpers, if you see on the right-hand side of your screen, have the skills you learned in PM Plus training impacted your own life? 82% of the helpers said yes. They've not only helped me, these are skills that I use. Even as someone working in the mental health field, the techniques feel very useful. I took bits of PM Plus into my own personal life. Those are results from our local project. If you'd like to go to the next slide, please. And here are just some of the data that are related to from our own pilot project in Minnesota. Over 2 years, we've trained over 116 helpers from 30 different organizations. We did the GAD-7 as an anxiety measure. Most of you are probably familiar. We saw nearly a 67% decrease from introduction of PM Plus to session number 5, which was then at follow-up of 20 weeks, still sustained. We saw similar results with the PHQ-9, about a 30% decrease in depressive symptoms. And then on the right-hand side, you can see that Cyclops score in which It's a self-report from the client. You can see what happens, the problems affecting people, the stress steadily decreased all the way to session 5, and then also maintained in both follow-ups as long as 20 weeks post-intervention. Want to go to the next slide, please? And here's just some helper feedback from Goodwill, Divine Connections, which is moms working with daughters in our BIPOC community. Client feedback, I've incorporated these skills into my daily life. I think, like I said, it helped me deal with social anxiety and my people-pleasing tendencies, so I feel more powerful. And then from the IRC, who does primarily group PM+, we taught PM+ strategies to immigrants working to resettle in Atlanta. Those supported by PM+ trained IRC staff reported reduction in symptoms of depression, also expect an increase of confidence in managing stress. So these are just general sort of examples from the field and the work that we've done over the last 2 years. I'll go to the next slide. So building on that success, after doing now training with psychological first aid, we're launching Self-Help Plus, individual and group PM Plus. Last year, EASE was released, Early Adolescent Skills for Emotions, by the World Health Organization. So we want to build on that success in training non-special to actually deliver care to that younger population, which I know is also a huge concern. And so that 10 to 15. So I will turn it over to Annie, and she can talk about EASE.
Great, thanks. So EASE is very similar model to PM+, as we said, 10 to 15-year-olds, although it seems like from the early data, the sweet spot is maybe around 13. And similarly, focuses on building skills within these youth to manage their own problems, manage their own stress. Based on cognitive behavioral therapy, it is also that similar model where we're training lay workers in the community. They go through about 30 hours of training and then are supervised by a licensed professional. And then this is what they deliver to the youth. There's 7 sessions. You can see some of the similar language from PM+, but focus on youth specifically. So understanding my feelings, how do I calm my body? So that's breathing, mindfulness. How do I change my actions? Going through some very specific, identifying them and taking small steps to make those changes, managing my problems, which we talked about already in the PM+, and then planning for the future. So they go through this in a group of around 12 youth. At the same time, caregivers are going through 3 different sessions. They're learning some of the same skills, but then a few more additions that are specific around parenting. So understanding big feelings, so kind of that same language that their kids are learning, they're learning so they can support that at home. But then also thinking about, suicidality, how would you manage that? What are those steps that they would take? Really the focus on quality time. That second session, really how does praise, how do you build up your child's confidence, but then also dealing with challenging behaviors and talking about that in a group to support each other, and then self-care. So because caregivers are hard to get to, they're busy parents, we can do these in person, but we're also have now created video content. Rick referenced, we have a learning management system, which is online. So we'll put a lot of this content online for them to do on their own, but you can also have discussion groups, because I think that group aspect, the discussion part, is part of the intervention. So we have been working closely with the new school in New York City. They did a pilot last year in after-school programs. So they also were working on PM Plus with the mayor's office post-COVID. The mayor's office then supported this EASE pilot. So they did 15 sites, 50 helpers, and reached 153 youth and 33 caregivers. This is just a quick synopsis of their data. It's similar measures that Rick talked about, the GAD-7, which is the anxiety measure, measuring depression. You can see all of the measures. It's hard to see actually, I realize, but lots of small little graphs, but the data all went in the right direction. Basically, they had very good success. The data isn't finalized, but this was like an early synopsis that they provided for us. We hope to get a little bit more information soon, but we now 2 weeks ago went through, they trained us on how to do EASE. So I'll talk a little bit about what we're doing to replicate that. So we are able to then jump in and take their lessons that they already learned in New York. And we're doing our own pilot in the Twin Ports, which is Superior, Wisconsin, and Duluth, Minnesota. We are going to pilot this. They did it only in after school programs. We are going to try this curriculum with 4 different organizations in 3 different settings. So we're working with the Boys and Girls Club of the Northland, Neighborhood Youth Services, which is Justice Impacted Youth, the Superior School District, and Harbor City International School, which is a charter school in Duluth. So we will be piloting it, and the Boys and Girls Club will be doing the summer camp program that will be starting next week. Neighborhood Youth Services and Boys and Girls Club in the fall will be after school programs. Superior will be doing it in school, as well as will Harbor City School. So the goal of the pilot is to test it in these different programs, also in Duluth, which is very obviously different than New York City, and look at how it works in our setting. Really looking at the training model and implementation needs. So that's one of the things we really learned through our pilot with PM Plus. We significantly changed the training from what the WHO had. It was like 80 hours of training, which just really wasn't feasible in the US context. And we were able to adapt that and make that more specific to the needs of the organizations we're working with. Identify any adaptations for the different contexts. We've already, as we have gone through the training, have identified a few things that we feel like in Duluth would work better, and then really collecting data to make sure that this is actually effective. This was our timeline. So we launched, as I said, early June, I think. With the training, Boys and Girls Club will launch next week with their pilot. We'll do another training just prior to the school year to get the other 3 organizations fully up and running. And then over that fall semester, we will do data collection throughout for the 4 different organizations, and then hopefully have some preliminary data in January, February. We already have a few organizations who are interested in doing a second stage of the pilot, so hopefully we'll do some adaptations, learn from that very first pilot, and then do a second round and scale that up a bit in the area. University of Wisconsin Superior is our research partner on this pilot, so the evaluation questions are really focused on what are the strengths and challenges within each of these settings. As I mentioned, there's 3 different types of settings that we'll be using. Difference in outcomes for participants by age. We'll be tracking a few demographic details of each of the participants and seeing, there is a big range, 10 to 15, and it feels unlikely that you're going to have similar outcomes and that's going to land the same. I think someone I see asked in the chat about 15-year-olds. I think our hypothesis is that 15, 16, 17 may benefit more from group PM+. The caregiver engagement and really how that influences things, fidelity to the model, making sure that helpers are able to maintain fidelity in these different settings. And then we are lucky that we have the Bridge to Health survey coming out next month, which is a population level health survey with mental health measures. So we're hoping over the next 5 years, if that can serve as our baseline, really, maybe we'll be able to track community level outcomes for this project. And that's it for the presentation, but would love to hear any questions or thoughts people may have, and happy to continue chatting.
Oh yeah, thank you all. Questions, what questions do people have? This is probably the third time I've heard this presentation, so I'm very excited. And there was at least one question so far about, you already have 30 organizations. Is there room for more? Are you looking to like train others? How can people jump on this bandwagon? Yeah, what's the process for training? And of course, is there a cost? This is real talk here. We're gonna
I see Chelsea, who is our ArcaMind program coordinator, just dropped our link into the chat, so people are welcome to reach out to us. And Annie, you can go ahead and talk about the process.
Sure, yes, we're always open to train more. We have kind of rolling courses going. To try to keep costs down for people, we try to pair different organizations. So obviously it's cheaper the more people you have. For PM Plus training, helper training, we can fit up to about 16 people. So we try to pair people with similar interests. But we can do it either on demand. We have it virtual and in person. Hybrid, we see it doesn't, if you have some people in person and some people virtually, that doesn't seem to work, but either all virtual or all in person has worked well for us. And for the full training, it's about $800 for PM Plus. I think it'll be similar for ease, but we also have some wiggle room. We can work with different organizations to try to meet their needs as financially.
You're also supporting train the trainer opportunities, like long term, kind of, yeah.
Yeah, so I mean, I think there's not much cost to continuing to implement PM Plus. You know, there's a little bit of a cost upfront, but we also provide all the materials for organization to then print. And then, yeah, there is a training of trainer options. We can make sure people are able to then repeat it and replicate it within their organization. And with the training, we also help with implementation support. So how do you actually get this up and running in your organization? You know, there might be contextual issues like scheduling and all of that type of thing that we can help with.
And we do some implementation assessment at the beginning, because with some of the community-based organizations that we've trained, we've learned that, you know, like our standard language, like helper and client, doesn't necessarily resonate with that population. So we've had to do some adaptations with certain organizations to reflect what makes most sense for them.
Yeah, can you build on that? Oh, go ahead, Rick. Yep.
Traci, I would add to that. So as an example, we did a training with the American Indian Community Housing Organization, and frankly, failed epic the first couple times that we did the training because it wasn't resonating. I was one of the trainers and thinking, well, we're missing something. So then sitting down at the table again and saying, help me understand. Something's not right here. And so number one, of course, we needed to start with smudging, because that would make good sense. Then we had a tobacco ceremony, and then we had words from the elders. And so with that, we could then start the training. So what we really need when we're doing the pre-implementation, to Traci's point, is that we need to know what is specific for the community that we're entering into, so that the training will always resonate. They also did not like the language of helper and client. It felt medical, it felt hierarchical, and so they at ACO would say, we are your PM Plus relative. You are my relative and I am your guide. So the helper became the PM Plus guide, and they were working with PM Plus relatives and really creating that sense of community. So all of those adaptations, it's the beauty of PM Plus being born, and we're doing this reverse learning model, is that it's been adapted many, many times. It's just not in the US context. So nobody else has done this work, and we can make those adaptations. And in terms of, is there room for more? Our vision is go big. Traci's vision was, at the beginning, we want to solve the mental health crisis. We started in the Twin Ports. We want to go statewide. We think we have a national model, frankly. We've done training on the East Coast, the West Coast. We're not in the Southern United States yet. Really trying to focus on Minnesota, which is why we're so grateful for this opportunity.
Just a comment in the chat, Cassandra says, yeah, this definitely goes back to the relationship with the person being the most important piece. It's always about relationships. If folks have questions and you want to ask them yourself, I am more than happy to bring you into the panel if you raise your hand. So as we continue, what other questions do you have? I guess there's something I'll fill in here. You talked about training loggers in psychological first aid, which I love. And you've also, I think, trained bartenders. Is that right? Or you're thinking about it?
It's soon to come. We're we're working with some of the local organizations to bartender and barbers training.
Love it. I think these are key people in our communities. I love it. Is there expectation or thoughts about equipping some of those individuals with these other tools as well? Or does that feel, because of the infrastructure, like there might be some barrier for that?
I think the bartenders and barbers concept is that we would do psychological first aid with everyone, and then through that help identify individuals in kind of the service community who would be interested in being trained as PM Plus helpers. And then people could kind of refer. So if everyone has psychological first aid and can identify people that may need to talk to someone, then they can have a referral. They know who the helpers are in the community. We've talked about having people, at the local YMCA. That's been a successful model that they can go there to get PM Plus. That would be free throughout the community. With the loggers, it's, I think, a slower progression because, as Rick said, it's really having these conversations for the first time. And it's been a bit interesting with the trainings. Sometimes people are like, what are we doing here? Why are we doing this? But it's the older loggers who have been in the industry for the longest. The 25 plus years in the logging industry has rated these trainings the very highest. And they're like, this is something we need to be talking about. Maybe it's because they now have the gravitas to speak in these groups, but they're like, yes, we need to be listening to this. This is a tool that we need. But it feels a little bit more like baby steps in that community. And maybe a few years down the road, we'll get to PM Plus, but right now we're focusing on that PFA piece.
There's also been a lot of discussion about emergency response. So fire, police, and not necessarily with the emergency response with the clients, but more the emergency response between one another. And that's something that we've explored as well as with our first pilot, the older adult population really became active with PM+. And we know that that elderly population is oftentimes some of the most missed when it comes to services. So we're talking about how do we expand it into the elderly community. And then obviously the first communication we had with you, Anna, was thinking about, the folks who are going into people's homes as community health workers or arms workers, and, recognizing that there may be an opportunity there as well.
Yeah. I know there's a lot of interest in that from that angle. And Traci, do you want to talk about conversations around how you might support that kind of implementation long term? Like, has there been progress in that area?
So we're actually actively looking for community health workers or organizations who have community health workers on staff to be able to pilot this within those organizations. And I think, as we talk about like a 5-session intervention, we also talk about, is there the likelihood of being able to do something on a shorter time frame too, like a 3-session intervention or even a single session? Because what we know is oftentimes when people are seeking mental health care, I think statistically they get 1 session, and for whatever reason. So then we start to think about, how can we even scale it down more? It may not have the power that a 5-session intervention does, but it is able to get them something to get them on a trajectory. So.
And I think part of the excitement about the community health worker group, they already, to receive community mental health workers services, there's typically a referral that's already made. So there's a professional who's already driving and saying, yep, this person really does need community health worker services. So within that, in a care plan or a treatment plan, or the language would change by organization, PM Plus could actually be part of what the care plan looks like, because it's evidence-based, it's outcome-based, there's metrics that can be associated with it. And so then thinking about it being observable and measurable and client-driven, all of that language really starts to resonate when you start talking about how do you put this into a care plan or a treatment plan in the daily work that you're doing.
Yeah. Nicole has a question. I'm going to bring her in, and you want to ask directly, which I love. Thank you, Nicole. Or I'm not trying. Did I say that correctly? Oh, we're having a hard time hearing you. Can you turn up your audio?
Can you hear me now?
Perfect.
I'm not sure if there's any Nicoles, but my name's Nicoli.
Sorry about that. Thank you.
Is it possible you're calling on me?
Yes, you had your hand raised.
Yeah, I did. Yep. My name's Nicoli. So, I have a question that kind of goes along the lines of how Rick was explaining how things needed to be adjusted to fit with the Native American group. So, he was saying that the first go around, it's like, oh, that didn't really seem to work out. Like, and so what can we learn from that, or what could we potentially do better? And then through kind of talking, and having some discussion and making some changes in language and process that more fit with that group, it seemed like there was more receptivity and a better working out with that group. So along kind of that same line, my questions are, once the person from the World Health Organization who is going to be those people who are going to be going into these groups of lay people and unlicensed professionals who are going to be then taking that training and implementing it in their groups and organizations, along with the workbook and the materials and the training, do those people then get a contact person or contact people to follow up with along the way in case there are questions, or to voluntarily check in with like, let's say a Rick or a Rick-like person, just to make sure, like, because I guess in my like practice or in my way of conducting, the therapy or model that I conduct, or and how I kind of decide whether something is a good modality to use, is to make sure that it doesn't just end up being, and I'm not suggesting that this is that, this is just an example from previous other ones, that it doesn't end up to be a 4 or 5 week training and then here's all your things, this is what you have, go ahead, do it, implement it, and then you kind of don't really know if that person who you trained is actually really successful, because you don't know if they're continuing to implement the way that they were intended to be using it, and like following
Some
up.
follow-up. Yeah.
Yeah.
Thank you,
Sorry,
Nicolette.
that's
That's a great
of words.
question.
Sorry, that was the best I could do.
That was perfect. Thank you. That's great. So what kind of supports do you offer for people or organizations as follow-up and sustaining, and a Rick-like person? If you don't have a Rick, who's your Rick-like person? I love that line.
Nicolette, thank you so much, because we did neglect to talk about what was typically called supervision, which was a daunting term. We changed that to coaching. And so once training is completed, we strongly encourage every organization that they do weekly coaching. And so it'd be weekly coaching with all of the helpers who went through the training together. And the coaching would involve, how did session 1 go? How did session 2 go? Did you have any difficulties? And we would say that coaching would continue at least through your first 2 clients, because we want to make sure that there's fidelity to the model, that we know that people are really comfortable. And so it's that kind of ongoing monitoring. We still have people who were cohort 1 and cohort 2, so have been doing PM Plus for 2 years. They still come to monthly coaching because they like the relationships that were established 2 years ago. And Annie, you probably have something to add in that regard.
Yeah, it's definitely one of the things that we learned through that pilot. I think we said we had worked with 30 different organizations and how important that support is. So thank you for asking the question. That I think that's true with a lot of training. It's hard to actually do it and apply it. And through that process, I think we also, not everybody feels like they can do it. So we do actually, we've kind of gone through the wording for this, but rate people's capacity to be a helper. So I think sometimes people go through the training and they realize, or we realize, like maybe this just isn't the right fit and they can play a different supportive role. But for the people who do want to, that, yeah, this coaching is a key piece to actually feeling comfortable in implementing it. And like Rick said, I think some of the coaching just becomes, it's like a cohort of support for each other, building a community within a community. So
that's a monthly call or monthly, is that an open opportunity for everybody that's been trained, or for your cohort, your specific cohort? Like,
ours is for anyone in Duluth that, or this region that's been that has gone through it. But we just started, I think next week, as Rick said, we've trained a couple different organizations on the East Coast, one in Seattle, one in Atlanta. So we're going to do a call across those different groups as well, and just see like, how is it going? You know, you translated the materials into this language. Can we borrow them? So trying to just continue that community going and the learning to make this process better for everybody.
Beautiful. Thanks,
And
Nicolene, for the
one other
question.
thing I would add is with some of the organizations, and Nicolene, this kind of ties into what you were saying, we often encourage, if there's an organization that has a licensed professional on staff, having them go through the training, because then they can have their own internal coaching / supervision within their own organization. And that's worked out really well, particularly when we've had instances of doing trainings and actually having that licensed individual from the CBO be the co-trainer with one of our RICs, because the language then really starts to flow nicely, and I think the buy-in is even greater because their own colleague is helping them to learn this, helping them coach, things like that.
But I could say, if I'm like a pastor at a faith community or something like that, I could take this and deliver this to people in my community, right? Even if I didn't have that. Is that true?
I think we've mostly been targeting CBOs who have vetted volunteers and staff because of the liability reasons and the assurance that they've gone through their background checks and everything like that. So the faith communities that we've actually worked with have gone through that process too. So we know that those people who have been trained as helpers are qualified to do so.
Got it. Thank you. Other questions? What other questions do we have?
Miss Mary had a question about, I'm a Silver Sneakers instructor with an existing 65 community. I love that question. We have somebody at the YMCA in Hermantown who is an instructor, and she might do Silver Sneakers. I'm not quite positive. She does. It's a perfect program because, once again, she's worked with a number of clients because she knows the people. And after class, she put up a flyer that she's a PM Plus helper. And she's actually been approached consistently by, would you do PM Plus with me? So yes, it definitely would work in that environment. We have success there.
Great. Great.
So Annie, there was also, or Tracy, could a local government agency potentially take implementing this on using its own resource?
Sorry, I missed that.
Yeah, I just answered it in the chat, but that would be a good example, I think, of that train the trainer. You know, we also have lots of those checklists and that implementation kind of assessment process that we would go through in the beginning, but we could kind of help walk through what that would look like. But absolutely, I think that would be a good and probably cost-effective way to implement.
Fabulous. Who other questions? What's your wildest dreams? You talked about wanting to be statewide or see this be implemented statewide. Is there another goal you have or dream you have?
So I'm going to get on my soapbox here because, I've been adjacent to healthcare for my entire career, so 25 plus years. And our licensed providers, as many industries, are so burnt out. And there is nothing that shows me that that's going to change. And so when we started talking about, we've got to do something, I want to transform how care is provided so that really those licensed individuals can spend the time with the people who really need that level of care. I want to get to people on the front end before they ever need to get to any sort of care. And, thinking about doing it differently, doing it creatively. And so when Rick brought forward these WHO interventions, I'm like, why haven't we been doing this? Because they're accessible, they're adaptable, they're usable by so many people. And we start to do it in areas with people where they're already comfortable seeing them, they're already engaged, and it really just opens up a whole new supportive workforce that hasn't existed before. So then I'll let Rick talk.
And I think because it's reverse learning, and we're only the second city, we may be the only city right now doing end-to-end implementation. ArcaMind might be it. We've done some work with Blue Cross Blue Shield Foundation of Massachusetts, and they're actually now referring people our direction because this whole idea of taking something that lived in other countries into the U.S., it's such a novel idea. And again, as a licensed professional who's been in the field decades, this is the intervention. This is the thing that needs to happen in order for us to really create that impact to change the way care is delivered. As a clinician, it would have been wonderful to know that somebody had done PM Plus before I ever saw them. Because now I have the skills base, I have a place to start. And it would have been wonderful to have for the wait list when we were dealing with a wait list in a professional setting. Yeah. So I just think the implications and the adaptations are unending with these WHO interventions.
I think a lot about youth workers, right? Because you talk about people who are already connected, they have relationships. There's some infrastructure there, and there's definitely a need for other tools. Yeah, so many opportunities. What else do people know? We can end early, but we can also keep going. If people have questions, you can jump in, raise your hand. Yeah. I don't know. How can we support these training opportunities for this? What are some of the partnerships, or how have people been structuring that? Maybe you've talked a little bit about your partnerships with in other states. Like, what are some examples? Like, do organizations pair up and parade funding or figure out a way to do that? What are some unique examples that you've seen?
I think from what we've seen, there's a couple. I think I mentioned in New York City, it's the mayor's office. I think, post-COVID, they really saw a need, and it's the mayor's office. There's a special initiative for mental health. So they've been funding and working with the new school to do some of these interventions. I think Rick mentioned Blue Cross Blue Shield Foundation in Massachusetts. So they funded a number of local organizations in Massachusetts. So, maybe finding a foundation that may support that this is a priority area for. And then I think there's the IRC just felt like they needed another tool. So they actually partnered with Georgia State University so they could be collecting data. So it's like a university partner and an implementer, so they can kind of be supported in a little bit different way. So I think there's lots of ways to set it up. As Rick said, it's really adaptable, and you can kind of envision it for many different communities in many different ways.
Those are great examples. Thank you. Jason has a question about how do you see this training changing the way mental health systems operate within a workplace?
That is a very good question, and a similar one that we have had. So what we are in the process of doing is we're getting close to the tail end of putting together a Delphi study that was done with medium-sized organizations, mostly, I think, finance-based, insurance-based, and some others, and really tried to drill down to understand what it is employees want, what gaps they're seeing, and how we could position this so that it would be more effective within a workplace. Rick has some thoughts regarding EAPs. I think that they have some benefit, but what we've also learned with those is access can be an issue. And, you know, if you're able to get your 1 or 2 sessions that your EAP allows, then oftentimes it drops out. And the idea of being able to use some of these interventions internally with your own staff, I think has some great potential. So there will be more to come on that.
Yeah. Yeah, I've seen a lot of, or some examples of models that are implemented more as training, you know, development, personal development, rather than through the EAP system. But there's lots of ways to approach something like this. So Margaret is grateful for the conversation. Thank you, Margaret. Thanks for sharing this important model, very doable, builds different skills and approaches for existing and emerging workforce. I feel like I'm missing a question here. Diana asks, can you share a little bit more on the methodology of the training? Like how many sessions, how long is each session?
Sure, great question. So what we started with was a 12-week training. And we know that 12 weeks for 3 hours, I believe they were 3-hour sessions, not feasible. So what we have now, since Annie joined us, we've actually put together videos before training. So what is PM Plus? What is adversity? What is breathing? So there's a lot of work that can be done before training even starts. And then it's a 24-hour training from there. We've done 3-day trainings. We'd recommend spacing those out a bit. The training itself is psychoed. So it's really introducing, this is managing stress. This is the background of managing stress. I, with my co-trainer, co-facilitator, would then model what PM Plus looks like, session 1. So I would be the helper, my co-facilitator would be the client. We would actually go through PM Plus so that people can see exactly what it looks like. Immediately after observing, then the training would involve breaking into dyads and doing practice sessions. So you hear about it, you observe it, you practice it. So day 1, you're going to do session 1 and session 2. Day 2 is session 3 and session 4. Day 3 is session 5. And then talking about if recruitment is something you need to talk about, risk assessment, what's your risk assessment protocol within your organization or the group with whom you work. So it's very interactive, and the feedback that we have consistently received, number one, don't ever call it a role play because that freaks people out. It's practicing, and it gives you the chance to see it and do it. And so we go into breakout rooms if we're doing it virtually, and then facilitators pop in and out of all of the breakout rooms. If there's somebody gets stuck or they don't quite understand, and then we switch roles. So 20 minutes of being a helper, 20 minutes of being a client, and then switch so that everybody can get the experience of what PM Plus actually is and what's it like to be a client and what's it like to be a helper with all 5 of the sessions. I hope that answers quickly enough. Annie, anything to add to that?
I'm not sure if you said it, but just to say there's a total of about 30 hours. So there's 2 to 3 videos up front, just so you're coming in with a base understanding, 24 live, either in person or virtual, and then some of that coaching and follow up.
Oh, yeah. Miss Mary, thank you both. Miss Mary made a comment about 35 years of experience training childcare providers and creating their own self-care training delivered across Minnesota providers. Training of trainers would be great. They train with the U of M SEED, Center for Early Education, I believe, and is planning to share this with them. So early educators, have you had any early childhood providers participate in this? Because while it may not be for young children, they interface with parents. And so might be another option.
I love that idea. I don't know why that wouldn't. I love that. Of course, because as you think about childcare providers, just like we talk about ease with teachers, it's not necessarily that the teachers would be delivering the ease, would likely have paraprofessionals delivering, because the paraprofessionals are the boots on the ground. In childcare, they're boots on the ground, and that's a whole different level of energy as a childcare provider, right? So thinking about how could they support one another and manage the stress and manage the problems and get social support. So sure, that's an exciting opportunity.
Yeah. Okay, good connection.
Oh, Miss Mary, yes. Congratulations for 35 years.
I know, right? April asked about examples of the curriculum activities. So I think you dove into that a little bit more earlier. And Annie, you said you would email some of the materials. I don't know if you're interested in, we could send that out to everybody who registered, or maybe some select materials, if that's possible. I have a question about when you take the training, is there some expectation that I implement this within so many months or weeks? Because I know that's always a challenge, right? You're really excited, you get this training, and then you have other things that you do, right? And then if you don't do it right away, it's easy to forget how to implement that, right? So any expectations or just positive encouragement, which is also good. Life happens. Life does happen. Yes.
So we provide a certificate. So you're technically an ArcaMind certified PM Plus helper. And we have not been actually releasing those until people have gone through their 2 clients and the associated coaching.
Nice. Okay. Is this certificate recognized throughout the state or the US? Jason asked.
It's, since this is so new to the United States, it is not, but we are currently working on that. So.
All right. We're making it be recognized right now.
Mm-hmm.
Yeah, and we actually, Anna, we talk about the sooner the implementation. So ideally, and we would do this in pre-implementation, as soon as training, that last session of training, think about the clients that you could work with, identify, we want you to come in with some names. I don't need to know the names, but come in with names of people that you believe would be good clients or that you could work with. And then immediately after you're done with the 3rd day of training, jump in. Let's get started, because coaching starts the very next week after the training is completed. So we've learned that, to your point, the sooner that you start, the better you feel.
Right, right.
And if you've done the training, it's so nice to actually walk out of a training and do it.
Right.
And everybody has the experience, the way the training is set up. So you've already done it once. Now just go out and practice it with somebody outside of training.
Do you, a lot of times they'll require co-facilitators to do these kinds of things. Do you encourage that, or?
For the training itself?
Yeah, to deliver, when somebody gets trained, then they deliver it. Do they deliver it in a pair sometimes, or?
If you're doing group, absolutely.
Okay.
If you're doing it individually, that's usually awkward for the client. So it certainly, that's why coaching is there, right? And we talk about it in training. Please remember, after you're done with training, the client does not know exactly what it is that you're trying to deliver. You're the one who knows about PM Plus. The client, to an earlier point, it's about that relationship. The most important thing about session 1 is establish the relationship. Establish what it is that you're going to be doing, and I'm going to be with you for the next 5 weeks. So it's much more about the relationship. You have a fidelity checklist in front of you, and you're going to know exactly what it is you need to do. We've actually created what's called a flip book. So it's like a workbook where the client will see one piece of information on the front, and on the back side, you get to see as the helper, you get to see the checklist.
Nice. That sounds really cool.
It's way
Mari
cool.
asked, is recertification required?
I just put in the chat, but it is recommended. It's part of our planning in the beginning with organizations that they would think about what does this look like ongoing, and not just the training. So, you know, once you do it for a year, obviously you're going to, some people, organizations are going to have turnover. So you're going to think each 6 months or a year, you're going to do some kind of retraining or training to new individuals that have maybe joined the organization. And we've seen that organizations, we just did our second round of training with 2 different organizations that we trained last year. The program's growing, they need more individuals, but also they've had turnover. So it's, as Traci mentioned, we're kind of working on that certification process. So maybe at some point it would be a requirement, but right now just a recommendation, and also just thinking through that planning, you know, 1 year, 2 year out.
Some sustainability. And then
we're sticklers for fidelity.
Right. What's the train the trainer, training of trainers? How many, like, have you done a lot of those, or how's that been implemented? How's that been going? Or are you still working towards that?
Right now we've done it twice. Once for locally because there was a number of organizations, so we needed, like, we don't have enough RICs to be able to do as much training as we need. And also just matching people with trainers that meet their needs so that we have a range of trainers. So we have done a training of trainer locally. And then we just did one, this group in Seattle, they were just doing it, I believe, with like a Spanish speaking refugee population, and it was going really well. So now they want to do the Hmong and Laos communities. So they added, so we did another training to add their different, to expand their program. But then a few of them, then they thought like, well, maybe we should just do this training of trainers. So we did one more round of training for them. And then some of those people did a 3-day training of trainers with us. And we kind of went through more of that, like, how do you train other people on this rather than just implementing it yourself.
Right. Miss Mary is encouraging that. Thank you, Miss Mary. This is great. I'm excited. If people have, okay, there's a few more questions. We have time for more questions. So Jason asked, this program seems like a bridge between life coaching and therapy. Is that an accurate read, or am I way off? Question. Life coaching, therapy, is this, how do you frame it? When you explain this to your mother, for example, how do you explain your work to your mom? What do you say? Yeah, we're doing this.
Hopefully this isn't offensive to anyone, but I think of it as CBT light, because it really was initially based on cognitive behavioral therapy. So that's where it's its roots come from. Otherwise, I will let Rick as a clinician answer because I am not a clinician.
In the very first session, when we talked about confidentiality and we talked about PM+, we are very clear that I'm not a therapist, I'm not a psychologist. I am here to teach you some strategies, real life strategies that you can use to help you manage stress and manage problems. That is my role. The caveat would be there are people, we have had clients in PM+ who have gotten to session 4 with strengthening social supports, and they say, you think maybe I should see a therapist? So we've actually had clients ask the question. We have also had PM+ clients who are currently in therapy. So they're seeing a therapist, and separate from seeing the therapist, the client has said, I'm going to tell my therapist that I'm really interested in this PM+ thing. And so they talk to their therapist about it. And so we've had that happen both directions.
Yeah, I mean,
It's a skill set.
it's a skill set. Yeah, life tools that we all need.
Exactly.
I always like to say adults, we haven't always been given the social emotional learning tools that many of our children are getting now in school. So
Correct.
life is hard. We need a lot of tools.
Yep.
And we need to be reminded of the tools, even if you had those skills at some point, right? Sometimes we need reminders. April has a good question. Do you have ongoing relationships with the WHO, the World Health Organization, and how was it that you all got trained? Are they supporting Minnesota US expansion?
Yeah, I can answer that. Yes, we do have an ongoing relationship with WHO. In fact, I presented at a conference a few weeks ago in San Francisco with the head of behavioral health for WHO, who's actually based in Geneva. So the history is that it was our partners from the New School in New York who had the initial connection with WHO, and they were trained through WHO. So then our New School partners trained us. So what I know through all of our conversations with WHO is that they have been interested for some time in seeing these interventions used in the United States, but they have not had the capacity to do implementation because of the adaptations that were necessary. So they've been very excited to kind of follow our journey to see how we've been adapting it and how it's being used successfully here. So does that answer your question?
You might also want to mention, so randomly, small world, that one of the individuals from that team moved to Duluth, Minnesota, and
All right.
saw the PM Plus poster at the local YMCA and got in touch with us. So he's on the strategy council, so it helps guide ArcaMind. So he's also part of that relationship.
Brilliant. Any other final questions? We still have maybe room for one or two more, if there are any out there. My final question maybe is nothing to do with PM Plus or ArcaMind. It's about what is behind you, Rick. Is that a mini bobblehead of yourself, or oh, you're on mute.
When I started at the foundation, we really do have a lot of fun. We work really hard, but as I started, it's a mini me.
It is a mini you. So there are multiple Ricks.
Well, hang on.
Oh, there's more.
It gets worse. There's also this.
Oh my gosh.
We have Rick on a stick.
Rick on a stick.
So if Rick can't be someplace, there's Rick on a stick, and he can go along. He's actually went to school with two of our grandsons because I couldn't make it to a grandparent day. So They each had a Rick on a stick. Papa on a stick. So we love what we're doing. We're passionate about the work that we're doing, and we also have a good sense of humor.
It's helpful. It's helpful. Another life tool.
Absolutely.
All right. Well, this is fabulous. I recorded it, and I'll send this out to everyone, including those who weren't able to attend. If you have other questions, we'll attach our emails. Yeah, I guess I'll share here what's, okay. One final question, and then we'll wrap it up. Diana, you get the honors. Diana asks, what's the greatest challenge you've faced in recruiting participants? And how do you seek to overcome those challenges? Great question. Are people lining up once you get to participate, or how do they recruit people? And, we talk about like, oh, don't talk about mental health. Sometimes, especially in some communities, right? We don't talk about mental health, but you could talk about stress.
Yeah. That was actually, I think, one of the big lessons that we learned in the pilot. I think in some cases, individuals came because they were interested in doing PM Plus, and they had a harder time recruiting participants. People that were attached to organizations had a easier time. So like our trainer that's Silver Sneakers at the YMCA, she is in a position where she's kind of client facing already. So people who had positions that were client facing in an organization and had kind of that support of the organization had a much easier time. So I think that was one of the shifts that we did in our training. We don't really have individuals sign up anymore. Maybe if it's just like informational, but to be a PM Plus helper, that they find, some of the retired individuals are part of a church, so they do it out of the church. So it's not to say you couldn't find a place to do it, but that seemed to be the largest challenge, and a lot of those individuals ended up not really implementing.
Yeah, or where people convene, like librarians, I could imagine.
Yeah.
Have a natural sort of space for where people convene.
Yeah, and I think we also learned, because we didn't talk a lot during the first cohort about how to get clients in your organization. And it was harder for that first cohort to be able to secure clients. So Rick, that was another adaptation to the training, was during the training, now there's a segment about how to solicit clients, get people in the door, correct language to use, because again, you don't want to say, hey, you could use some help, to be able to just phrase it more correctly so people are feeling good about stepping into it.
Right. Okay. Thank you, Diana, for that final question. And we're going to gift everyone with 10 minutes of free time so you can do something good for yourself and enjoy maybe a longer lunch or a walk. It's nice out. It's not 100% humidity today. So, all right. Thanks everyone for participating, and I hope beautiful things emerge from this conversation today. So have a great rest of your day.
Thank you for hosting.
Thank you.
Thank you.